2, 1. Please start. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on multidisciplinary management of hepatocellular carcinoma and colon cancer. And with immense pleasure, I would like to invite Dr. Priyanshu Chaudhary, who is Senior Consultant Medical Oncologist at prestigious Shalby Hospital, Mohali, for the welcome and introductory note and to carry out the further proceeding. Over to you, sir.
Thank you, and good evening to all. And I would like to welcome all the participants in this today's live webinar on multidisciplinary management of HCC and colon cancer. So, without wasting any time, I would like to invite Dr. Arvind Guru, who is a consultant in surgical oncology at Max Hospital, Mohali, a very dear colleague and esteemed friend also. And I would like to call him for a talk on management of localized HCC, the surgical options which we have. Over to you, Dr. Arvind.
Hello.
Yes, sir.
Am I audible
Yes, sir.
and visible too?
Yes, sir.
Okay.
Yes, sir.
Thanks a lot, Dr. Priyanshu, for that lovely introduction and this opportunity to meet all the lovely people here and to present this. So I'll start sharing my screen. Is it? Can you see my slides?
So just make it full screen.
Hello.
Hello. Yes, sir. Your slides are visible. You need to make it full screen. Yes, sir. You can proceed.
That's
Go
it?
ahead. Yeah.
Okay.
Sir. Perfect.
Take care. So I'll be talking on management of localized HCC, the surgical options or the surgical management of a localized HCC. So just a brief epidemiology. North, Western Africa and East Asia together account for around 80% of the cases. India as such is a low incidence region for HCC, with HCC being the 13th most common cancer in India, with only 4% of the deaths being attributed to HCC. And surgical management of localized HCC basically revolves around three things: to prove that the lesion is HCC, prove that the lesion is localized, and then to cut it out, provided the patient can tolerate the surgery is technically feasible, and the patient will go home without liver failure and other complications. So to prove that the lesion is HCC, that's the diagnosis, the simple rule that works over here is if it looks like a dog, barks like a dog, and is coming to bite you, then it is a dog. So in the high risk group, a lesion that is greater than 1 centimeter size or higher, just the dynamic imaging is sufficient to diagnose it categorically as HCC. This high risk group being the cirrhotics and hepatitis B carriers. So what imaging is recommended? It is a multiphasic abdominal CECT or a CEMRI. The purpose being, one, to diagnose the lesion, and second, to assess the tumor burden in the liver and to assess the lymph nodes in the regional territory of the liver which are metastatic if found. So the imaging diagnosis is given by the Lyrad's criteria, and the essential features of that is a late arterial hyperenhancement, non-peripheral venous or delayed venous phase washout of the contrast, and an enhancement of the capsule or the pseudocapsule in the delayed phase. Then there is the threshold growth, that is the increase in diameter by greater than equals to 50% increase in a time period of less than 6 months if it is done for a interval scan after say a lesion is detected on screening. So these four are the major criteria of LIRADS. And second, LIRADS also gives a criteria for venous invasion, and that is the invasion of major vessels around the area. So when do we biopsy a lesion that is suspicious on imaging? So one is that when we have a doubt whether it is a cholangiocarcinoma intrahepatic or a combined cholangiocarcinoma and a HCC, or suspected on raised tumor markers of the otherwise, or if the lesion is highly suspicious but does not meet the imaging criteria specific for HCC, or even if it meets the imaging criteria, the patient is not high risk, or in cases where there is cardiac cirrhosis of congestive cardiac failure, vascular cirrhosis of Budd-Chiari syndrome, congenital hepatic fibrosis, and some other causes. Also, prior to ablation and arterial therapies, it is a good idea to confirm the diagnosis, especially. And another thing is when we are planning to start systemic therapy for it. So the second part is we have proved that it is an HCC. Now we are going to prove that the HCC is localized. So HCC is commonly associated with lung mets, bone mets, nodal mets, adrenal peritoneal mets. In the most common being the lung mets, and the other systemic mets are the bone mets. Lymph nodal mets are found not so commonly. Some people have given it to be around 50%. So additional imaging that is recommended is based on skeletal symptoms. If they are present, then a bone scan is required. Otherwise, a CT chest is required. So CT chest can be a contrast CT when it is done along with the contrast CT of the abdomen, or it can just be a plain CT, especially when done as combined to the MRI of the abdomen. PET scan has a very controversial role. It is not a definitely recommended investigation, but it can help in certain scenarios. One big scenario is when we are trying to transplant in localized HCC. That is one scenario where practically nobody would move ahead without doing a PET CT. And when we are trying to assess whether the nodes have a high uptake SUV value, or whether the intralesional SUV is too high, then we may get an idea about the biology of the disease. So in essence, a workup, preoperative workup, is summarized by this acronym of WILTS, that is like viral markers for cirrhosis. Then there is imaging for diagnosis, staging, and the detection of portal hypertension. That is a portal vein Doppler is required. We do a liver function test, albumin, PTINR, basically to calculate the CTP score. And then we require tumor markers, especially AFP. AFP is not elevated, then PIVKA2 becomes important. CEA and CA99 should be low in a classic HCC. Then is the scopies, upper GI scopy for grading varices and bleeding tendencies because of the hypertension. And generally a colonoscopy is a good idea to rule out whether it is a secondary from a colon lesion. So the cut it out. So surgery for localized HCC basically hovers around these three factors. Can the patient tolerate surgery? So if the patient has a good performance score of ECOG less than equals to 2, then only we are contemplating any kind of surgery. Or even the systemic therapy might not be tolerated by a patient who is ECOG 3 or 4. So if the patient can tolerate surgery and will go home without a liver failure, that means the condition of the underlying liver is good enough, which is generally a compensated cirrhosis or non-cirrhotic, or the MELD score is less than 10 to 12, then we can consider surgery. So what kind of surgery? If it is technically feasible at all, that will depend upon the number of lesions, the size of the lesions, and the exact location of those lesions. Some of these will fit the transplant criteria, some of these will not fit the transplant criteria. Then it will either require a downstaging or a bridging therapy. Bridging is when we are waiting for a transplant, and downstaging is when we are out of the transplant criteria and we want to sort of bring it into the transplant criteria. And for these, ablation is one thing. Transarterial therapies in the form of TACE, TARE are another commonly used therapies. When there is no option left, then usually people go over to systemic therapy or SBRT and EBRTs. Evidence with SBRT is coming up fast, but they are not the preferred ablative means for ablation, and arterial therapy for downstaging and bridging are the most commonly used. Another very important concern that comes into picture over here is whether the patient actually has a donor. This is very important for two aspects, because these transplant criteria are essentially designed for a society which has a large cadaveric donor base. And if we are talking about a living donor, people have expanded the criteria or sort of extended the criteria in living donor, because a donor is available, there is no waiting list, and sometimes sort of bridging or waiting for the cadaveric donor makes people drop out of the waiting list. So they can be either fitting the criteria or they can be made to fit the criteria by downstaging their tumors. When it is not a transplant candidate and or it is a smaller lesion and both options are available, then we actually consider whether we can actually just resect it for the time being if the underlying liver does not need any transplant as a management of the CLD picture. In those cases, bigger question is what is the future liver remnant left after the resection, and if required, we can do some interval portal vein embolization and try to get away with a safe resection. So who are the patients who won't go home without liver failure after surgery? So these are somebody having a CTP score greater than B7, so B8 and above, or CTP-C, MELD score of greater than 10 to 12, shrunken liver on imaging which will fall short after the resection, a post chemotherapy liver also complicates this picture, and this clinically significant portal hypertension that is more than grade 2 varices on endoscopy, presence of splenomegaly, presence of a little bit of hypersplenism and platelet count of less than 1 lakh, and presence of ascites. These are very bad prognostic markers for any patient to undergo liver resection. These are more of an indication to consider liver transplant. So this is a comprehensive flow chart which I have tried to sort of give a very simplified view as to what would be our approach. So if a patient has a bad performance score, ECOG 3 to 4, most of them will end up in best supportive care. Some of them will merit a transarterial therapy or systemic therapy. If the patient has a good performance score, a fit patient, then we assess for basically 4 things. One, the person should not have any metastasis, no extra hepatic disease, no major vascular invasion, and the number of lesions should be less than 4. If any of them is positive, this patient goes for either systemic therapy with or without some ablative or regional therapies. A role of surgery is out in this case. So only after this assessment comes the assessment of the liver. So if it is a compensated cirrhosis, that is child A, B, or child B up to B7, and or alternatively a MELD score of less than 10, then with no clinically significant portal hypertension, the treatment depends upon the size of the lesion. If there is clinically significant portal hypertension, or the liver is not well compensated, we should consider transplant criteria, whichever they might fit into. There are couple of criteria. US or the cadaveric programs most of the time follow either the Milan criteria or the UNOS criteria, and in some cases UCFS criteria. But there is a sort of a concept in the living donor circles of up to 7 and the metro ticket system of taking people up for transplantation. For a patient who is having an upfront AFP of 10,000 or a liver tumor size greater than 10 centimeters, the first and foremost, they need to undergo an arterial therapy to reduce the size and to bring this AFP down for any other curative option to be contemplated. So coming to a person having good performance score, non-metastatic, compensated liver, no clinically significant hypertension, portal hypertension, we come to this part of the flowchart. So for a lesion that is less than 2 centimeter, ablation surgery is almost the same, though long-term data with ablation is not as strong as with a resection, but it can be taken to be the best modality with the least invasive treatment. For a lesion that is greater than 2 centimeter, the necrosis might be lower than 90%, so there might be some recurrence areas. And especially if a lesion is greater than 3 centimeter, or there are multiple lesions, then we need to consider means other than purely ablative means. So this ablation can be a RFA, a microwave, or even SPRT. And for greater than 3 centimeter, for a well-selected patient, surgery has the best outcome. But even in these child A patients, people would not want to contemplate more than a bisegmentectomy or more excision of more than 2 segments of the liver at the same time. Though technically leaving around 40% of the liver is adequate in a cirrhotic patient. For a patient who is having a 5 centimeter tumor, most of them, either if they fit a transplant criteria and get a living donor, they straight away can go for a transplant, or they might even go for a resection after a portal vein embolization or directly. But 5 centimeter tumor is generally a big tumor. Going ahead without ablation or bridging or downstaging is usually not a very good option for them. So in a sense, but this ablation and bridging is not always possible for say superficial lesions which are very close to the liver capsule, very close to the heart, very close to the gallbladder. For those type of exceptions, many times either percutaneous ethanol is preferred, or resection becomes a primary way of treating them. So for FLR,
conclude your presentation in 2 minutes.
For an FLR of greater than 40 to 50% is usually not a problem. So coming to the surgical approach per se, open resection with or without ablation of a multinodular lesion, which can also be done laparoscopically or robotically, is usually the preferred option. Right now, laparoscopic or minimally invasive means have become standard of care. There is a concept of anatomical segmentectomy versus non-anatomical segmentectomy, but generally the idea is to get a clear margin. Try for 5 mm, but greater than 1 mm of clear margin is adequate if the capsule is intact.
So sorry to interrupt, but 1 minute left, so.
Yeah, so this is my last slide anyways. So then there is the issue of any adjuvant therapy, which has not been shown any promise by the STORM trial, and margin positivity is a strict no-no. We should never have a margin positive situation because it is very difficult to manage later on. So I hope I was clear with this thing. If anybody has any questions or we want to discuss anything, you're most welcome.
Thank you, Dr. Arvind. I think so. You have made it pretty clear for the medical oncologists like us who are very know very less about hepatic surgeries. So I think so. I have two questions. First is, I mean, what would be the percentage of people who present with a resectable mass who are able to undergo surgery?
So see, the thing is, there is no particular.
In your clinical practice,
in my clinical practice, most of the patients present without a donor and a big mass, which will not fit in the classical criteria of, say, Barcelona clinic or the UNOS criteria. In those, the best approach is usually to do a transient arterial therapy, and if the patient is well compensated, then go for a resection. That is the usual sort of thing. Only very few people, maybe like 20%, would come with a small 3 centimeter mass. Most of those things would be incidentally detected or a screening detected for somebody who is very compliant with hepatitis B or hepatitis C treatment and
yes, sir. And another question is that suppose we have a large unresectable mass, and we proceed with systemic therapy, and we've had a very good response, in the measure of FDG avidity or washout or size also. So can we take that patient for a surgical approach later on?
Yes, that patient, see, for liver directed therapies and regional therapies, it is definitely the way to go. But systemic therapy is usually not used when we do not have a patient, till we don't have a patient which will not tolerate a regional therapy to the liver. Systemic therapy is not the preferred therapy in that case.
Yeah, but with the availability of
so many of your
therapies, so a lot of in practice we tend to overuse probably systemic therapy. Akhil will be discussing shortly. So I think so we might be more clear in the subsequent discussion, but definitely I have a lot of patients who actually respond well to systemic therapy, and we don't know what to do. Probably Akhil would help us with that.
It is like, if I can use a liver directed therapy as a neoadjuvant, technically, then there is no reason why not to use a systemic therapy as a neoadjuvant.
Yes.
Yeah.
I think so. Thank you, Dr. Arvind, and as usual, very nice presentation. So I think so we'll move on further and would like to call Dr. Akhil Monga, who is consultant in intervention radiology at Paras Hospital, Panchkula. And over to you, Dr. Akhil. He'll be enlightening us with local regional therapies for HCC.
Hi, Dr. Priyanshu. Thank you so much. And I really appreciate Dr. Arvind's talk. It was absolutely lucid, even for, the people when we interact between HCC management, it really helps us out to understand the perspective of the surgeon and the medical oncologist to then maybe where to plan the best therapy for the patient. So I'll quickly move on to the local regional therapies. And since sir has also covered a bit of the imaging, I think I would try to avoid the initial slide where I also added some of them regarding the imaging as well. So basic thing, we all know that we do surveillance using UV ultrasound and AFP, as sir said. This is the place where we can actually pick up patients for surgical therapy, because these patients who are at regular surveillance may have initial small HCCs, 2 centimeters, 3 centimeters, that can directly go for surgical resection, and that is the best cure. Usually another point I want to bring about is the size of this detected lesion. If it is less than 1 centimeter, we should not directly jump to a 3D CT or an MR, because it is very difficult even for the radiologist to kind of justify the characteristics in that smaller lesion. So all this washout and the things that we talk about in the Lyrad's criteria become very difficult in less than 1 centimeter. So at that point, it's still better to repeat the ultrasound, see the growing character of the lesion. And if it is growing, then you can go ahead with the further scans. But if you find it more than 1 centimeter, that is where, you know, the 4D CT and dynamic MRs are able to give us a better and clear picture regarding the lesion being an HCC or not. So the basic idea behind that imaging is that as the nodule, from a cirrhotic nodule, it goes towards HCC, it loses the OATP receptor. So there's a delayed intake as compared to the regular intake of the liver, and the arterial supply becomes dominant as compared to the portal supply. So you have a lot of arterial enhancement which goes away, and then in the venous and portovenous phase we have delayed a washout. So these are few images where you describe HCC as nodular, multinodular, infiltrative. So this is a typical nodular kind of lesion where you can clearly see a capsule or a demarcation from the normal liver, whereas this is more of an infiltrative type of a lesion where you really cannot picture that where exactly the HCC starts and what is the arterial supply. So it makes an important argument for us when we are doing even transarterial therapies, because the results are much better in a nodular lesion. You can picture out and map out the arteries to such lesions, whereas in these cases it becomes quite difficult because they are getting supply from multiple vessels. So this is the kind of images we get in MR. So multiphasic MR, this is a T2 image when we see the hyperintensity. So when HCC is hyperintense, in diffusion, it should show diffusion restriction. And then the multiphase MR, we can see the arterial enhancement, the washout, and the delayed filling in. So these are the characteristics that point out. And this is where MR, with the diffusion imaging being present in MR, I feel MR is slightly better than triple phase CT whenever it is possible to do. There's also another advantage of MR when we have done a previous test, especially if it's a conventional lipidol test. So the lipidol deposition in CT masks any underlying enhancement. So in those cases also, it is better to do a multiphase MR than a multiphase CT. So these are the characteristics I think already sir have mentioned, so I'll go along. Important thing is these criteria are only for cirrhotic patients, Hep B patients, and prior HCC. And there are some areas where less than 18 years old, so in pediatric population, they have not been seen in patients with butt carry, chronic portal vein occlusion. So these criteria do not apply in those patients. And as I said, that it depends on the CT and MR, both are equally accepted in the guidelines. So LR4 and LR5. So when you see a CT or MR report, if you get an LR4 or LR5, then you are a lot more sure about the thing being HCC. And we need to be a little more careful and have to undergo further investigations if the LR readings are less than that. Some of the things that we need to be careful about or must ask about our radiologists is that whether it can be a mimic. So always look out for an hemangioma being picked up, especially in patients who are Hep B, Hep C positive, because we are already looking for a possibility of a HCC. So be careful that we don't have any hemangiomas, which also may show some amount of arterial enhancement. Cholangiocarcinomas and as such metastasis can also sometimes present from second primary. So now I'll try to move towards the locoregional therapies. So the important stage is where the locoregional therapies come into picture as a stage A to C. So it could be the ablative therapies in the early stage or the transarterial therapies in the intermediate stage HCC. So I'll be dividing the talk between the ablative therapies and the transarterial therapies. So in the percutaneous ablative therapies, we have either chemical ablation, thermal ablation, and a newer non-thermal ablation, which is but not very easily available at most centers, which is the IRE, irreversible electroporation, because it's a kind of costly thing, but it has certain niche indications. Right now, I don't think apart from PGI, we have this available quite easily. Thermal ablation, radiofrequency, and microwave are the most commonly used ones, and where microwave scores slightly above the RFA, I'll mention those in the subsequent slides. So chemical ablation was quite a lot used when I was at AIIMS because it's a very kind of cheap therapy as compared to RF and microwave. So a lot of patients who could not afford microwave and RF, it was extensively used in our initial experience at AIMS. And it causes coagulative necrosis plus ischemia. So when it goes into the vessels, it causes platelet aggregation, and for the cells, it causes cytoplasmic dehydration. Very simple technique. We take a 20-22 gauge Chiba needle, and with 95% ethanol or 40% acetic acid, we just inject it at multiple places. So it can be done in multiple sessions, and we have to.
Sir, good evening, sir. Yes, sir. Yes, sir. Thank you, sir.
Pankaj Goyal's audio is on. If he can help me with muting that.
Pankaj, can you call Dr. Pankaj and tell him to mute his audio, please?
Oh, 1 second.
So this requires kind of multiple sessions sometimes, and we can do one per week for 3 weeks, even in slightly bigger region. But when you come to the real results, I think RF ablation and microwave ablation have better results as compared to the percutaneous ablation.
And I am Dr. Selena, medical advisor from the oncology team of Dr. Reddy.
Yeah, thank you. So for RF ablation and microwave ablation, the basic principle is the thermal ablation. In RF, it is the RF generator, it is ionic agitation and frictional heat, which causes coagulation necrosis. And we generally get a range of 60 to 100 degrees Celsius with the aim of destroying at least a 0.5 or 5 mm margin additional to the tumor. So that is how we plan. There are set maps which give us that this kind of size, this kind of shape. If we give therapy for certain amount of time, this much area will be ablated. And our preferred modality is ultrasound. Unless the nodule is not visible on ultrasound, we try to do this under ultrasound guidance, because of the movement with the liver movement with respiration. We get a much better idea, and we can place it right in the center of the lesion under ultrasound guidance, which is real time. The issues is the heat sink effect or charring of tissue. So on RF, it can be sudden high intensity heat, and the charring can prevent the conduction of the heat. So it really travels by the adjacent area. So if in between there is a charred tissue, the adjacent area might not get the heat. And also because of the heat sink effect, the vessels in an area where there are a lot of vessels, the heat is taken away by the blood that is coming in. So that can also lead to reduction in the amount of tissue that gets ablated, or the percentage of the tumor that gets ablated. These is where, as previously Dr. Arvind had mentioned, that in certain locations we have a bit of difficulty, that subdiaphragmatic location, close to the bowel, close to chest wall, or near a blood vessel, where RF slides has a slightly higher complication rate. Whereas either we can use certain kind of protective measures, or microwave has shown to be a little better with lesser complication rate. So the techniques that we can use is hydrodissection. We can get a needle in between the bowel loop and the liver with the tumor, and kind of put normal saline in between, and prevent that conduction of heat directly to the adjacent bowel. Similarly, a pneumoperitoneum can be created between the diaphragm and the liver, so that we get this distance. A balloon can be put in between the viscera and the adjacent tumor, which may be on the periphery, using inflation of the balloon with contrast. These are some examples where we can see that there is a peripheral lesion here close to the peritoneal wall, and we have hydrodissected this area with normal saline. This again here is the probe placement that has been done after the hydrodissection, and we can see that very little amount of heat will be transferred, because now we have this fluid barrier in between. Similarly, this is another lesion where it's close to the viscera here, and we put 2 probes as well as a balloon. So this balloon has been inflated in between the structures, and that prevents any kind of heat transfer to the adjacent viscera. So microwave, it has also similar properties, and it uses electromagnetic waves instead of the direct frictional heat. In these cases, the heat transfer is much faster. So the procedure is faster, more efficient energy deposition, and the susceptibility to heat sink effect and the charring of tissues is much less as compared to the RF. So right now,
Sir, sorry to interrupt, but time's up, sir.
I think so we can continue for 5 minutes. You started late.
Yeah.
Okay.
So these are the transarterial therapies that we're talking about. The concept of TACE, as I mentioned prior, was that there is a hepatic artery and portal vein supply, and as the tumor differentiates, the HCC has a much higher arterial supply. So we utilize the dual supply of the liver and are able to introduce the chemotherapeutic agent directly into the region, that is the tumor vessel, and then being selective, we prevent the damage to the adjacent liver, and using embolization, we also induce ischemia. So it is a two-pronged attack, that is with the chemotherapy and with the ischemia. So it has to be done in more than, either in a more than 5 centimeter single lesion, but the involvement should be less than 50% of the parenchyma, and no portal vein involvement. So portal vein involvement is because we are also closing down the artery, and if the portal vein is also involved, we can end up causing damage to the liver. So it can also be used in congruency with the RF and microwave in lesions which are 3 to 5 centimeters, as I said, bridge therapies. And the transarterial embolization can often be, really helpful for patients who have undergone a rupture. The most commonly used drug that we have is the doxorubicin. And in the conventional TACE, we mix it with lipiodol, which is an oil made from poppy seeds, and it is radio opaque and kind of has mild embolic properties, but we usually in the conventional TACE have to then put embolic material and shut down the artery separately. This is a lesion that was an HCC enhancement on the arterial phase, and we went into selective vessel, and you can see here that after putting the lipiodol, there's a lot, the entire tumor lights up. So this is the situation, and after embolization, we see no arterial supply in the area. The problem with TACE is that it is, mixtures that we make are totally, non-standardized. It is based on the experience of the individual, the number of treatments, what is the embolization material that we used is not kind of standardized. So these disadvantages of TACE were then taken up by DC beads. So these are a slightly more standardized technique, which help in increasing the drug delivery, consistent and standard protocol, and the systemic effects are even less. So this is how it looks. We mix it with these DC beads, and after 30 minutes, we can see that the chemotherapeutic agent has been taken up entirely by the beads, and it's a much better graph. We can see in 30 minutes, almost 99% of the drug has been taken up. Another thing that we need to watch out during our procedures is to make sure that we do not miss any extrahepatic collateral. So often when we realize that our TACE is failing, it is very important that we go back and look at the CT angio and see if there's any extrahepatic collateral that we might have missed and is getting the supply from there. And that is why it's more of a partial response as compared to the kind of complete response we can get if we kind of get the entire blood supply. So as I said, next is the small, quick representation of the follow-up. So this is how we follow up: 6 weeks, 3 months, 6 months, 9 months, and 12 months. And then the patient goes on to the routine surveillance. TARE is the new technique. Here we can, kind of even do patients that have portal vein thrombosis, because we do not embolize the vessel, and it's purely based on the radiation therapy. Yttrium-90 is the the one which it's all started, but because of cost issues, we also have rhenium-188 and iodine-131 in India, which is getting used. Deuterium is a much more standardized glass and resin particle that we are using, and unresectable HCC with portal vein thrombosis is the most niche indication, though now we can use it in other places as well. So this is how we can use radioembolization now, even as an ablative treatment. Upfront, it is being used. In downstaging treatments, as somebody is not into the liver transplant criteria, he can be downstaged using radioembolization, and non-surgical candidates and in advanced HCC, it can be used. So the response assessment is something I would really want to talk about, because I was recently having a talk with Dr. Priyanshu as well. And I realized that there is some, with these immunotherapies coming in, with the transarterial therapies coming in, it is important to understand that the normal morphological anatomical imaging is not sufficient. So a diffusion weighted MR, a CT perfusion, and a triple phase MR is very important, because now the simple RACIST criteria previously used for most tumors talks about size reduction. And in these cases, the size reduction is not the only thing that we are looking at. It is the enhancement pattern that is very, very important. So you might have residual lesion post arterial therapy. The lesion might be seen on the imaging, but it is not enhancing. So we need to look at the enhancing portion of the lesion so that we can quantify it much better. So I'll just show these examples that the enhancement might be much lesser than the actual tumor size. So if this is the initial tumor and then we do not see enhancement in part of it, then that means that part of the tumor has got treated. So it's not just the size, it is also about the enhancement pattern of the post-treatment lesion. So this is a, see, if we use the RACIST versus the modified RACIST criteria, this lesion, which is the baseline imaging, on the post-treatment imaging is almost similar size. So if we purely look at the sizing, we would end up calling it a non-responder. Whereas the moment we see the enhancement pattern, we see that there is more than 30% response, so it becomes a partial response disease. Similarly, here again, the lesions have not disappeared, but according to the modified RACIST criteria, this is complete response because there is absolutely no enhancement in these lesions. So the last point is the recommended modality for screening is ultrasound. Diagnosis, multi-phase CT and MR. I usually prefer a multi-phase MR if the patient is, kind of take that time of managing with the respiratory movements in MRI. If they are, able to stay in the MR room and cooperate with the breathing exercises, it is better to do an MRI. Treatment decisions are based on modified BCLC staging and in a multimodality meeting. We need to realize what is the final aim in, talking with the oncologist and the surgeon. Ablation techniques are much better. They have, better survival rates if it is possible. If it fits the criteria, ablation should be the first technique used. And then we go to the transarterial chemo as well as radioembolization. With the 3 to 5 centimeter block, I think using a combination of both is even better. And it should, the arterial therapy should be done first, because once the ablative therapy is done, the chemotherapy may not go into the ablated tumor. And tumor response, very, very important that we think about the modified RACIST criteria and we look at enhancements and not just the size of the tumor. Thank you.
Thank you, Dr. Akhil, and thank you so much for enlightening us about how to get a proper response. And so one question from me is, what are the facilities which are available at your institute with respect to HCC, and what is the cost approximately for each of these facilities?
Actually, thankfully, we have all the facilities out of these available because a nuclear medicine department is required for radioembolization. So since at my center, we do have a good nuclear medicine department as well. We are able to offer all of these therapies to the patient. So surgical oncologists are present. Then we have, TACE, TARE, and the ablative models are easily rented. So whenever I have a case, they come in. Usually a arterial therapy or an ablative therapy will cost somewhere around 1.5 lakhs to the patient, plus and minus depending on the kind of hardware that we use. So anybody, it won't usually go about 2 lakhs in my setup. I kind of make sure that nobody get to pay more than 2 lakhs, and we try to bring ablative therapies towards 1.5. Transarterial therapies end up going closer to the 2 lakh segment, but we are able to offer more of them. Radioembolization, we have 2 modules. Either we can use the yttrium 90. The yttrium 91 is quite costly, so the medicine itself costs around 7 to 8 lakhs. Then the pre-scan, post-scan, that kind of goes to around 8-9 lakhs also for the patient. But in patients who can't afford and are only feasible for radioembolization, we can get iodine 131 from the Atomic Institute, and we have tie-ups with them. So it costs another 50-60,000 to get and acquire that medicine. So then the TACE cost and the TARE cost is just a difference of 50 to 80,000. So if I am putting TACE at around 2 lakhs, it will be around 2.5 to 3 lakhs for the TARE. So we can manage TARE for a patient, but then it is not the standardized yttrium technique that we'll be using.
Okay, thank you so much. If there are any questions more, or should we move on? I think so. We can move on now. Thank you again, Dr. Akhil, and it was wonderful listening to you. So we move on to the next session, which is sponsored by Roche, and I would like to invite Dr. Kanika Sharma, who is a consultant medical oncologist at Max Hospital, Mohali, to give a talk on role of atezolizumab in first-line unresectable and metastatic HCC. Over to you, Dr. Kanika.
So yeah, good evening, everyone. I'm Dr. Kanika Sharma. I'm currently working in Mark's Hospital in the medical oncology department. So today I'll be discussing about the atezolizumab and bevacizumab as a first line in unresectable HCC. So till now we have discussed about the resectable part, the surgical and the non-surgical part. So now in this, so a little brief about the incidence of liver cancer that is presently there and the mortality associated with it. So when we talk about the incidence, So when we talk about the incidence, it is the 6th most common cancer overall. And it is 3 times more common in males than female. And when we see the Globocon 2020 data, so the mortality rate is the 3rd highest in the population. So when we see the global incidence also, the global incidence of around 8 lakh, more than 8 lakh cases, new cases per year are being recorded. And more than 75% of these cases, they occur in a less developed region of the world. So these are the 5th most common cancers in male and 9th in female, the incidence being higher in male. So whenever we talk about a liver lesion, so primary liver cancer, so around 90% of them is constituted by HCC. The remaining 10% is constituted by an intrahepatic cholangiocarcinoma or an angiosarcoma or a hepatoblastoma in children. So the most significant factor that contribute to HCC is the presence of cirrhosis, which is seen in around 80 to 90% of the patients. And even in the diagnosis also, even in the subset of a cirrhosis, if patient is having a characteristic radiological appearance of a nodule, then it is characteristic of HCC without even histologically proving it. So what are the various factors contributing to cirrhosis, thereby HCC? Hepatitis B and C infections, alcohol, non-alcoholic steatohepatosis, and aflatoxin. So the remaining around 10% of the patients, they do not arise from cirrhosis. So when we come to the Indian scenario also, there were around 35,000 new cases of liver cancer in 2020. And that is the 10th among all the cancer, with a significant mortality of around 33,000 patients who have died because of the liver cancer in 2020. So there are various unmet need when we talk about HCC. The majority is, like we were discussing with Dr. Arvind also, that most of the patients, they don't come at an early stage. So we were discussing about the resection or the non-surgical part. So patients actually, they don't give that much opportunity that we can try all those. So majority of them, they are detected in the advanced stage, maybe because of the lack of symptoms or lack of awareness. And when we talk about the 5-year survival rate in them, that is very low, that is around 2.3% at 5 years. So till now, the current options were the TKI in the first line setting of sorafenib, then comes the lenvatinib. But with them also, the progression-free survival is poor with these agents. So as we were discussing, the sorafenib was discovered in 2007. And after that, for around 10 years, there were no new agent that was approved in HCC, and we were just treating with sorafenib only. And after 2017, basically in the last 5 years only, we have a multiple agents now in HCC. So in the first line only, besides sorafenib, we have lenvatinib, atezolizumab plus bevacizumab. So all 3 agents are approved as a first line. In the second line and beyond, we have cabozantinib, regorafenib, ramucirumab, and the other immunotherapy agents. So what is the rationale when we discuss about this atezolizumab and bevacizumab? So HCC, it's an immunogenic tumor. So when we see the cancer immunity cycle in HCC, there are various factors. So there is a release of cancer cell antigen, which leads to antigen presentation, priming. There is infiltration of the T cells into the tumor, which are being recognized by the cancer cells. So all of these, even in some cases, the spontaneous regression has also been seen because of this anti-tumor activity. But as we know that tumor is a dynamic structure, and eventually cancer finds its way to overcome this anti-tumor activity by expressing PD-1 or PD-L1 and CTLA-4 reception to evade this immune mechanism. So when we talk about this combination therapy, so it is both an immunotherapy as well as an VEGF inhibition. So when we talk about the atezolizumab, it promotes the T cell activation by allowing the B7-1 co-stimulation, and also it restores the anti-cancer immunity, which we have seen in the previous slide. When we come to the bevacizumab, that is an VEGF inhibitor. So first of all, it promotes the dendritic cell maturation, as well as it normalizes the tumor vasculature, thereby increasing the T cell infiltration into the tumor cells. So based on this principle, IM Brave 150 trial was conducted, which was a phase 3 trial, which tested a first line therapy as compared to sorafenib in unresectable HCC. So in this, they have taken locally advanced or metastatic and unresectable HCC who have not received any prior therapy. They have stratified according to the performance status of the patient, whether there is any macrovascular invasion or an extrahepatic spread was there, and whether the baseline alpha fetoprotein was less than or more than 400. So they have divided in 2:1 ratio to atezolizumab and bevacizumab versus sorafenib 400 mg, and it was continued until the loss of benefit or unacceptable toxicity. And when we have seen these features, so they have also included the high risk feature, that is the high risk patients who have an invasion of a main portal vein, bile duct, or more than 50% of the liver is occupied by the tumor. So the patients were equally distributed between the both arm when we have seen the age, sex, even the BCLC score. So around 82% of the patients were in the stage C in both the arms. And all of them, they have either hepatitis B or C infection were there. So sorry. So when we see about the progression-free survival, which was the co-primary endpoint, so there was a statistically significant difference, as you can see from the Kaplan-Meier graph, that it was 6.8 months as compared to the 4.3 months in the sorafenib arm. And at 6 months, when we see it is around 55% versus 37% in the 2 arms. So when we see the follow-up therapy, so when we have seen that how many of the patients required a second line or the further line of the therapy, so it was significantly higher. So only 30% of the patient in the atezoli arm required a second line, whereas around half of the patient, they have received a second line, and in which around 25% of the patient, they have received the immunotherapy or chemotherapy in the subsequent lines. So when we see the overall survival, so initially the median overall survival was not reached in the immunotherapy arm versus as compared to the sorafenib arm. But on the when we talk about the updated OS, so it was 19.2 months as compared to the 13.4 months in the sorafenib arm. And when we see the graph is consistently separated along the years. So at 6 months, it was 85% and 72. And when we go 1 year down the line, also at 18 months OS, then also 52% of the patients were alive as compared to 40% in the sorafenib arm. So when we see this forest plot, so almost all, you can see all of the subcategories, it was favoring the immunotherapy arm, more so in the patients who have advanced disease, that is stage C, or the patient who have a lower alpha fetoprotein of less than 400 and who have increased disease burden like an extrahepatic spread or macrovascular invasion. So these group, they have benefited more with the immunotherapy arm. So when we talk about the response rates in even in the immunotherapy, 6 patients, they have 18 patients even have a complete response on this regimen as compared to none of the patients in the sorafenib arm. And there was almost doubling of response was seen, that is 12%, whereas it was almost more than double, 27% in the immunotherapy arm. And when we see the further follow-up, that is the updated response, it was even higher, that is 30% as compared to only 11% in the TKI arm. So when we talk about the safety, and we have discussed the efficacy, when we talked about the safety of this regimen, so the grade 3, grade 4 side effects were similar between the two arms, whereas the treatment related withdrawal, it was slightly higher in the immunotherapy arm of 16% as compared to 10% in the TKI arm. So the side effect profile was different between the two arms. So in the sorafenib arm, as we all know with the TKI, the diarrhea and the hand-foot syndrome were higher in the sorafenib. When we talk about the immunotherapy, the side effect profile was more because of the bevacizumab part. So patient have a hypertension, they have proteinuria. So that was higher in the immunotherapy arm. So even when we talk about the grades of side effect also, so it was almost similar when we talk about in all the 3 first line agents. So grade 3 and grade 4, there was no significant change in the side effect profile. When we talk about the bleeding event, considering that it has a bevacizumab also and the HCC, the patient have portal hypertension and also the risk of bleeding is already there in this subset of the patients. So, but when we see that the patient who have a baseline varices as well as who needed treatment at baseline, they were even higher in the little sorafenib as compared to bevacizumab, and there was no significant increased risk of bleeding when we see between the two arms. So even in this also, the hepatitis, because of the immune related, it was a little bit higher. So there was, if we talk about any grade, it was 43%, whereas grade 3 and grade 4 around 21% in the atezolizumab arm. So besides the side effect, the other important part that they have also included in the study is the quality of life. What was the functionality of the patient and whether there was any improvement in the symptoms, that is the fatigue, pain, appetite loss. So all of the features that were presented. So they have checked this quality of life questionnaire. They have included every 3 weeks while on the treatment, and even after completion also, every 3 months patient were evaluated for it. So when we see the time to deterioration, so the deterioration free rate, when we see in the sorafenib arm, even within the first 3 months, there is a significant drop in the patient. They have a significant deterioration in the first 1 to 2 months only, whereas it was consistently maintained after 6 months. The graph is actually going flat after that. Whereas in sorafenib arm, there is a significant deterioration in the first 6 months. As you can see, half of the patients, they have deteriorated on treatment. So it was around 11.2 months as compared to only 3.6 months with sorafenib. And same when we talk about the their patients' perception of their well-being also. So there was significant, just not in few months where we say. So it was around 13.1 month versus 4.9 months in the sorafenib arm. So when we talk about the systemic therapy as per 2021, so in the first line, all the 3 agents are approved, sorafenib, lenvatinib, and atezolizumab plus bevacizumab. And the subsequent line, cabozantinib is approved, ramucirumab in the patient who have alpha fetoprotein more than 400, regorafenib can be used. And if not used in the first line, then the other immunotherapy agents can be used. So the left side of the...
Hello, ma'am, I would like to request you to conclude it in a minute, if possible.
Sure.
Thank you. Thanks a lot, ma'am.
So the left side of the graph we have already discussed in the first 2 seminars. So the later one in the inoperable and the metastatic setting. So all these agents are now available. So even in the ESMO guidelines also, when we see the state C and the mostly in the state C, so all the 3 agents are approved as first line. So concluding my talk, the combination, they have demonstrated efficacy in the patients with unresectable HCC in the phase 3 trial, and they have demonstrated a statistically significant and a clinically meaningful improvement in overall survival and PFS, and also a delay in the deterioration of the patient-related quality of life as seen. So this trial, they highlight the benefit of targeting multiple steps in the cancer immunity cycle. So basically targeting both the pathways, and it has the potential to transform the current treatment paradigm. So any patient who is affordable and the cost is not the constraint, so this regimen can be considered for the first line in hepatocellular carcinoma. So thank you.
Thank you, Dr. Kanika, for such a wonderful talk. What is your personal experience, if any, with this combination? Would you like to tell us about that?
So I have actually treated 2 patients on this. So one, the patient, they have actually improved on this regimen, and after that he had actually with all the immunotherapy regimen, the fatigue is a major part. So once patients started having it, the fatigue, they keep on coming. Otherwise, the tolerance is not an issue of this regimen.
And what was the dose of bevacizumab? 15 mg you are using?
So we are using 15 mg per kg only. Yeah.
Okay, so just I mean, I also have 2 patients I've used at a lower dose, somewhere around 10 mg per kg. So fatigue has not been an issue with that. And one had a near complete response, another one is, due for response evaluation. So I agree with you. There's no major, IO toxicity as anybody would, be afraid of. And although, cost is definitely an issue, but with more and more, people having some, insurances and all that, so probably in future we would be having more patients on this combination. Yeah. And I think so it's a very well tolerated, option, and definitely I would say in personal experience, it has a faster and probably higher response rates also.
As compared to the other agents that are available in first line, even the response is pretty good actually.
And I think so in real world practice, I personally feel that if we go strictly by the Child-Pugh criteria, then we would be having a very few percentage of patients who would actually fit into the criteria for this combination. So I think so probably in a Child-Pugh B also we can use and C probably plus minus, but definitely with the Child-Pugh B we can use. That is my take on this. So thank you, Dr. Kanika. So now we move on to the next session, the next talk, which is by Dr. Piyush Mehta, who's consultant medical oncology at Sohana Hospital, Mohali, and he'll be talking about management of HCC beyond the first line. Welcome, Dr. Piyush, and over to you.
Thank you. Thank you, Dr. Priyanshu, and good evening, everyone. So as discussed by Dr. Kanika, so I think that she has discussed a lot about the treatment options in the first line and a bit introduction about the treatment option in the second line also. So I will be discussing about please share my slides.
So can we share sir slide?
Okay.
Sir, can we do that?
So can we share your slides?
Yes, please.
Okay.
Okay, so management of HCC beyond the first line. Next slide. So we can see that we have seen the role of nowadays atezolizumab along with bevacizumab and sorafenib, lenvatinib. If we have used all these in the first line setting. So now with the IMBRAVE 150, I think that Dr. Kanika has discussed in detail about the use of bev and atezolizumab in this first line setting, and the criteria, the patient profile has been discussed by Dr. Kanika already. So in the second line, we have regorafenib, cabozantinib, ramucirumab, nivolumab in a monotherapy, and nivo-ep in combination, and pembrolizumab monotherapy also. Next slide. So what is the mechanism for resistance? So it's mainly activation of the insulin-like growth factor, and by fibroblast growth factor signaling. So we can see in the control and in the sensitive, we can see like insulin-like growth factor 1 in the control and the sorafenib sensitive, and then they have an acquired resistance. So there is activation of these two pathways leading on to acquired resistance. Next slide. So now regorafenib, which is a molecule, so we can see the activity of regorafenib and sorafenib in this. So the potency, the activity that is more towards like VEGF3 and like fibroblast growth factor receptor. So next slide. Now, resource trial. In this, the HCC patients with documented progression during sorafenib treatment, that is in the first line, they were stratified by geographic region, that is in the Asia or versus rest of the world, and a macrovascular invasion, extrahepatic disease, performance status 0 or 1, and AFP level less than 200 or less than 400 or more than 400 nanogram per ml. And 2:1 stratification was done, and the regorafenib was given at a dose of 160 milligram once daily. Back, please. Previous slide. Previous one. Yes. So regorafenib in a dose of 160 milligram once daily, with 3 weeks on and 1 week off. So 4-week cycle. 379 patients were enrolled in this arm, and in placebo 194 patients. And this was a trial which was conducted in 24 countries in both the North America, South America, Asia, and Europe. And all patients received all supportive care, and the treatment was continued till progression or the withdrawal from the trial. Next slide. So in this, we can see that the regorafenib, that median OS of 10.6 month with a placebo of 7.8. Next slide. So it was published in Lancet Resource, like regorafenib in patients who progressed on the sorafenib. So I have discussed about this trial. It was a phase 3 double-blinded placebo-controlled with better OS compared to placebo after progression on the sorafenib. Next slide. So now the role of cabozantinib in second line after progression on the first line treatment. So it acts on both vascular endothelial derived growth factor receptor 1, 2, 3, MET, and AXL. So it acts on more pathways compared to the another molecule. And so Celestial, it was a phase 3 trial design. In these patients with HCC who were not amenable to curative treatment, they were enrolled. All patients were in the child A, and they have received prior sorafenib, and the disease progression was after more than or equal to prior therapy for HCC, and performance status 0 or 1, and no uncontrolled hypertension. So they were randomized in a ratio of 2:1, and cabozantinib was given in a dose of 60 milligram once a day, and primary endpoint was overall survival. And prior to randomizations, the patients, they were stratified by the disease etiology, whether it is because of hepatitis B, C, and depending upon the region, like Asia versus another, and whether there was any macrovascular invasion present or extrahepatic spread of disease was there or not. Next slide. So we can see the results like the Kaplan-Meier. We can see that 470 patients, they were enrolled in the cabozantinib arm, and 237 in the placebo, and the median overall survival, that was 10.2 months in cabozantinib versus 8 months in the placebo arm. And in the PFS, we can see that the curve separating. We can see the PFS with cabozantinib of 5.2, and with placebo it's 1.9 months. Next slide. So next is the REACH trial. In this, ramucirumab was used in the second line in patients following the first line treatment with sorafenib on progression on sorafenib. And so it was a phase 3 trial, and the patients, they were stratified according to the geographic area and the etiology of liver disease. All patients, they were in child pug A, and performance status 0 or 1, and they were enrolled in 1:1 randomization with ramucirumab is 8 milligram per kilogram every 2 weeks and best supportive care, versus placebo every 2 weeks, and the treatment that was continued till progression. The primary endpoint of REACH trial, that was overall survival, and secondary endpoint of PFS and overall response rate, and patient reported outcomes. Next slide. Next slide. Yeah. So as we know, as already told by Dr. Kanika also, that in the AFP also we can see the difference significant compared to the overall. So in REACH 2 ramucirumab versus placebo in HCC with elevated alpha fetoprotein. So we can see in this graph also that same, like it's just a repetition. With median overall survival with ramucirumab of 8.5 months versus placebo of 7.3 months. It was the latest update. Next slide. So in the HCC in BCLC class C in second line, so we have option of regorafenib, which acts upon the RAS and MAPK pathway, cabozantinib acting on the MAT, AXL, and the VEGF pathway, and then ramucirumab, more active in those patients with AFP more than 400 nanogram per deciliter. So these are the three options on second line. Next slide. Then coming on to the immuno-oncology drugs, immunotherapy drugs, we have like nivolumab, ipilimumab, and pembrolizumab. Next slide. Next slide. So we have nivolumab, checkmate 040, and pembrolizumab, keynote 224. These two are the trial, and in nivolumab, the objective response rate, it was 18%, and the duration of response, which lasted for more than 12 months, it was 55%. And in the pembrolizumab arm, the objective response rate was 17%, almost comparable. But in the nivolumab arm, both Child-Pugh A and Child-Pugh B till a score of 7. So this were patients, they were enrolled in this study compared to the another drugs in this combination, in this immunotherapy. Next. So we have nivolumab, 154 patients, sorafenib pre-treated patients, they were sorafenib intolerant, they were enrolled, and effective therapy for HBV positive patients that was started along with this nivolumab, and a response rate was 14% regardless of any etiology or alpha fetoprotein level, and the duration of response, that was 16.6 months in HCV, and it was not reached in other etiologies, and median overall survival of 15 months. And in the pembrolizumab arm, sorafenib pre-treated patients, they were enrolled, and it was used in the second line. Sorafenib intolerant patients, they were also included, and patients with hepatitis B virus, HBV positive, they were included, and the therapy for HBV, that was also continued. And the response rate, that was 17%. Duration of response was more than 6 months in 77%, and the median overall survival, that was 12.9 months in pembrolizumab. Next slide. So in keynote 394, pembrolizumab in patients with previously treated HCC, in a dose of 200 milligram 3 weekly for less than or equal to 35 cycles versus placebo, and patients with advanced previously treated HCC, previously treated with sorafenib and progression with BCLC stage C, Child-Pugh A, and that was taken ECO 0-1. Secondary endpoint was PFS, overall response rate, and the duration of response and time to progression. Next slide. So median study follow-up was around 33.8 months, and 90.7% of the patients, they have received sorafenib as a first-line therapy and in this pembrolizumab with best supportive care, the overall response rate, that was around 13% compared to just around 1% in the placebo arm, and median duration of response, that was 24% in this compared to the 5.6% in the placebo arm. So median PFS of 2.6 in pembro arm, and in the placebo, it's just 2.3. Next slide. Now, any post-study systemic anti-cancer therapy, yes, that was given in pembrolizumab in 152, and with PD-1 or PD-L1 in 62%. Next slide. Adverse event, that was definitely more in the pembrolizumab arm compared to placebo, with a more than grade 3 around 14% in pembrolizumab compared to 6% in the placebo and best supportive care, and 1 treatment-related death in pembrolizumab arm compared to none in the placebo during that period. Next. So a final analysis was that pembrolizumab with best supportive care, that improves the outcome versus placebo, and no new safety signals they were reported, and the findings were consistent with those in the keynote 224 and keynote 240. So these results, they provide additional evidence for supporting the use of pembrolizumab as a second-line therapy for advanced HCC. Next slide. So keynote 240, it was a phase 3 in second line, another study of pembrolizumab versus best supportive care, 200 milligram, same dosage, 2:1 randomization. So response was assessed every 6 weeks, and the treatment was up to 35 cycles or till progression or toxicity. Next slide.
So I would like to request you to conclude in a minute.
Yeah. So phase 3 trials with single agent immune checkpoint inhibitor in HCC, pembrolizumab, like we have 240. It's a similar trial like pembrolizumab versus best supportive versus placebo. So it support the use of pembrolizumab over the placebo. Next slide. Now, IO combination in HCC is with nivolumab and ipilimumab, and FDA has given approval for this combination. Next slide. So CTLA4 and PD1. So mechanism of action, this is different for PD1 blockage and CTLA, and the combination that as we are using in melanoma and in lung cancer. So it has also got approval in HCC in second line. Next slide. So nivo plus ipi combination, I have like nivo in a dose, fixed dose, nivo plus ipi for 3 weekly, and followed for 4 cycles for this combination, and then nivolumab that is continued flat in a dose of 240 milligram versus nivo ipi and in a dose of 3 milligram, and that followed by single agent nivolumab, and the treatment that was continued till progression. And so we can see that the similar overall response rate DCR, and they were observed across all 3 arms with consistent higher overall response rate, that is more than 30%. And patients in arm A, that is the highest CR and most promising median overall survival of 22.8 months. We can see in this graph that in the arm A, we have overall response, median overall survival of around 23 months in this arm, in which nivolumab along with ipilimumab at a dose of 3 milligram per kilogram that was used 3 weekly for 4 cycles, and followed by flat dose of nivolumab 240 milligram. Next slide. So you can see that the side effect profile that is almost like similar, and most common side effects, they were immune-mediated adverse event, they were rash, hepatitis, adrenal insufficiency. Higher rates were observed in arm A compared with arm B and C, and also the median overall survival that was better in arm A compared to arm B and arm C. Next slide. So now the FDA has granted an accelerated approval of combination of nivolumab and IP in patients with SCC who have received prior therapy with sorafenib. So this was on the basis of this study, accelerated approval for this nivo-IP combination. Next slide.
I would like you to please conclude now.
Okay. So this is just NCC, and we can see regorafenib, cabozantinib, ramucirumab, lenvatinib, and sorafenib. And another drug which we can use if we have priorly used TKIs is either nivolumab or pembrolizumab or combination of nivo-IP. That's it. I think that is the last slide. Thank you.
Now I'd like to request if there are any questions from anybody.
Which I think so we can take questions at the end. We are already running late.
Okay. So now I would like to call upon Dr. Priyanshu Chaudhary, who is Senior Consultant Medical Oncologist at Shelby Hospital, Mohali, and also the convener. So
thank you. I would like the organizers to.
This session is sponsored by Dr. Reddy, sir.
Thank you. So can you allow me for screen sharing?
Yes, sir. You can share your slides, sir.
Okay, so are my slides visible now? Are my slides visible?
Yes, sir.
Are they moving?
Yes, not yet. Yes, it's moving,
okay.
sir.
Okay,
Yes,
perfect.
yes.
So,
Okay.
good evening, everyone. So, we'll be discussing regarding EGFR inhibitors in metastatic colon cancer. So, we have the latest paradigm trial results, which have, given us much hope and clarity regarding what to use and which side. So, we'll be discussing first line panitumumab versus bevacizumab in combination with modified FOLFOX6 for RAS wild type metastatic colorectal cancer, the paradigm trial results. So to begin with, we have to see whether it's what to use in left, what to use in right, is left the right approach, and what is the right sequencing. And first of all, we should know how important is selecting the right treatment in first line metastatic colorectal cancer. The selection is paramount because when we move from first to second to third line, the overall response rates decrease from as high as 69% to 41% to 22%. And the median PFS also decreases from 8 to 12 months to 4 to 9 months and to a dismal 2 to 4 months in the third line. And the number of patients eligible for therapy also decreases drastically from nearly universal in first line to 45% in second line and to less than 20% in third line. So we all know that colorectal cancer is not a homogeneous entity, and there are different characteristics which influence treatment choices in metastatic colorectal cancer. And the therapy should be tailored according to individual patient needs. The patient characteristics can be, age, comorbidities, prior treatments, and performance status. While the molecular characteristics include RAS, RAF, MSI, HER2, which we'll be discussing later on. And tumor characteristics include the tumor burden, resectability, and tumor location, which is very important. So in RAS wild type and BRAF wild type left side, what is the impact on therapy of a left-sidedness? So various studies have shown that tumor location is considered the master prognostic factors. There are clear-cut differences between the left and right-sided tumors. The right-sided tumors are more common in women. They are more associated with MUTY-associated polyposis. They have a higher incidence of PIK3CA mutation, BRAF mutation. They have a high incidence of MSI being high and CIMP being high, and CMS1 phenotype is their characteristics. They have usually poorer prognosis, whereas the left side are more common in men, associated more commonly with FAP and HER2 overexpression, KRAS mutation, and epithelial receptor overexpression, TP53 mutation, APC mutation, and CMS2 subtype. And they have a usually better prognosis. And if we group the molecular and clinical factors by tumor location, we should consider tumor location a master prognostic factor, a theory supported by most physicians. So, all the guidelines, major guidelines consistently recommend anti-EGFR agent for patients with a left-sided metastatic colorectal cancer, irrespective of the treatment goal. So treatment sequencing is also very important. First line left-sided tumor are the addition of anti-EGFR or anti-VEGF definitely will be discussing that anti-EGFR have shown a better survival with panitumumab showing very impressive results. So this was the first trial, that is the PRIME trial, which was a randomized phase 3 trial of addition of panitumumab to modified FOLFOX4 as a first line. In the subtype, it was shown that in patient who had a wild type KRAS, there was a significant prolongation in the median PFS, 10 months versus 8.6 months. And with the addition of panitumumab in the first line in KRAS wild type metastatic colorectal cancers. Similarly, the overall survival in the final analysis was also better, 23.9 months versus 19.7 months in the KRAS wild type population. So, based on this study, we know that adding an anti-EGFR or anti-VEGF antibody to chemotherapy improves the overall survival of patient with unresectable metastatic colorectal cancer, with the median OS being close to 30 months. And in comparative trials, post-hoc analysis of RAS wild type patients show inconclusive results with the US CalGB SWOG trials showing that OS was similar for cetuximab and bevacizumab, while in EU FIRE 3 trial, the cetuximab improved OS versus bevacizumab. So based on these conflicting results, this trial was designed. And the benefit of an anti-EGFR antibody may be enriched in RAS wild-type patients with primary tumor originating in the left side of the colon and rectum. And PARADIGM is the first prospective trial to test the superiority of panitumumab versus bevacizumab plus standard chemotherapy for patients with RAS wild-type and left-sided metastatic colorectal cancers. So this was a PARADIGM trial design. It was a phase 3 randomized open-label multicentric study in which patients with RAS wild-type metastatic CRC were taken who had unresectable disease, no previous chemotherapy, and an age between 20 to 79 years. ECOG performance status of 0 to 1 and at least one evaluable lesions. So the patient were randomized 1:1 to panitumumab plus modified FOLFOX6 versus bevacizumab plus modified FOLFOX6. And the primary endpoint was an overall survival in the left-sided population. And if significant, and it was, the OS was analyzed in the overall population too. And the secondary endpoints were PFS, response rates, duration of response, R0 resection in the left-sided as well as the overall population, and safety in all treated populations. The stratification factors were institution, age, and the presence of liver metastasis. This was, the patient disposition. In the end, for efficacy analysis, the panitumumab group had 400 patients, out of which 312 were left-sided, and in the bevacizumab group there were 402 patients, out of which 292 were left-sided. The data cutoff was for January 14, 2022, and the median follow-up time was an impressive 61 months. So a little bit of the statistical considerations. The final analysis included OS as a primary endpoint, which was tested through the hierarchical method. All data were reported and are based on a database log of February 10th, 2022. The primary endpoint one, which was the OS in left-sided population, required a p-value of less than 0.04202. And the OS was to be tested in overall population only if the overall in the left-sided OS in the left-sided population was significant. With the primary endpoint 2 of OS in overall population with a p-value of less than 0.05. So it was a hierarchical study design, and the targeted number of events were 420 events in the left-sided population, and with a 80% power to detect a hazard ratio of 0.74, the two-sided significance level was 0.04202. So these were the baseline characteristics of of the two groups. If we see they were well matched in the two groups, whether it was left-sided or the overall population. So coming to the results, which were the primary endpoint 1, which was the overall survival in the left-sided population, it was statistically significant improvement in the median overall survival in the left-sided population with a hazard ratio of 0.82 and a p-value of 0.031, which met the primary endpoint of OS in the left-sided population. And if you can see that even at 5 years, that is at 60 months, there was an impressive 32% patients were alive compared to just 21% in the bevacizumab arm. So almost a third of the patients were alive at 5 years, which is a very impressive data. And the primary endpoint 2, which is the overall survival in the secondary, in the overall population, it was again significantly better at compared to the bevacizumab arm with a hazard ratio of 0.84, which was again statistically significant, a p-value of 0.030. So again, if you can see that even at the end of 5 years, almost a third, 29% of the patients were alive in the overall subgroup 2. So if we see the subgroup analysis of overall survival, almost all of the patients in the left-sided population in the almost all groups have derived benefit more with panitumumab compared to bevacizumab. Now coming to the progression-free survival, although we know that OS was significantly prolonged with in the bevacizumab arm in the panitumumab arm compared to the bevacizumab arm, but the same was not true with the progression-free survival. The progression-free survival was similar in both the arms, both in the left-sided population as well as the overall population. Now coming to other efficacy outcomes, which were the response rates. Again, response rates were significantly higher in almost 11% higher in the panitumumab arm, especially in the left-sided population, 80%, 80.2% versus 68.6%, and in overall population they were 7.7% higher, 74.9% in the panitumumab arm compared to 67.3 in the bevacizumab arm. The disease control rates were although similar, with more patients having stable disease in the bevacizumab arm. The median duration of response was also higher in the panitumumab arm, with in the left-sided tumors it was 13.1 versus 11.2 months, while in the overall population it was 11.9 versus 10.7 months. The R0 rate was also higher with the panitumumab, 18.3 versus 11.6 in the left-sided population and 16.5 versus 10.9 in the overall population. So it was also, it can be used easily for the conversion therapy. Now coming to the adverse events, if we see, the two drugs have a different toxicity profile, and if we see panitumumab had more skin toxicity with dermatitis, stomatitis, and dry skin being pretty common. Although the grade 3 or 4 side effects were less compared to the overall side effects we see. And there was, the hypomagnesemia is a very well-known side effect of panitumumab arm, and we usually routinely test for magnesium levels for that, and a patient might require supplementation too. While there were significantly significantly different side effects like GI and hypertension with this bevacizumab, which are on the expected lines. So if we see subsequent systemic treatment, almost most of the patients, more than 3/4 of the patients received a second line of therapy, which were chemotherapy and this as a backbone was, and bevacizumab and the panitumumab arm was received around 44% patient in the later lines, as well as other VEGF inhibitors like ramucirumab and 10% of the patient. While almost 45% of the patient in the bevacizumab arm received panitumumab and 12% received cetuximab in the later lines of therapy. So in the right-sided population, the overall survival again was not superior in the panitumumab arm, which was as expected, and the subgroup analysis actually showed that most of the subgroups showed a benefit of bevacizumab more than panitumumab in the right-sided tumors. Similarly, if we see the PFS in the right-sided, again, it was not superior with panitumumab compared to bevacizumab arm, which is on expected line. The response rates were also more with bevacizumab in the right-sided tumors, and the disease control rate was also slightly better with bevacizumab in the right-sided tumors, although the R0 rates were similar in both the arms. So I think with this trial, we have more data of what to use in left and what to use in right. And as we can see that the phase 3 paradigm trial met the primary endpoint, demonstrating the superiority of first-line panitumumab versus bevacizumab in combination with modified FOLFOX6 in the left-sided and overall metastatic CRC population. The median OS in the left-sided was 37.9 months in the panitumumab arm versus 34.3 months in the bevacizumab arm, significantly better in left-sided, as well as in the overall population, 36.2 versus 31.3 months. The median OS exceeded 36 months in the panitumumab patients, while those in bevacizumab were consistent with the previous reports. And in right-sided, there was, numerically lower median OS with the use of panitumumab. Although PFS was comparable between the two arms, the response rates and R0 resection rates were higher with panitumumab in the left-sided as well as the overall population versus bevacizumab. The left-sided median PFS was 13.7 versus 13.2. Response rates higher, 80.2 versus 68.6. And the R0 resection rates again higher, 18.3 versus 11.6%. And in the overall population also, the median PFS was similar, 12.9 versus 12, but the response rates were higher, 74.9 versus 67.3. The R0 section rates were again higher with panitumumab, 16.5 versus 10.9. There were no new safety signals which were observed. Both treatments had manageable side effects. And these results support that panitumumab plus modified FOLFOX6 as a first-line therapy for patients with RAS wild type and left-sided metastatic colorectal cancers. So this is the latest and the best data which we have for treating patient based on their tumor sidedness. And I think so it is a very well tolerated drug compared to cetuximab, which has a lot of concerns regarding infusion reactions. So thank you, and I think there are some questions which we can answer.
Thank you so much, sir. Sir, we have received a question in our question answer box. Kindly reply, sir.
I think so I'll reply in the chat box itself. We can move further, and we're short of time.
Yes, sir. Yes, sir.
So I think so. I like to invite my very dear friend and senior Dr. Manish Sharma, who is consultant and head of unit in medical oncology at Rajiv Gandhi Cancer Institute, Delhi. And he is the one who has taught me oncology from day one. So it's a very big honor for me to invite him. Over to you, sir, and a very good evening.
Thank you, Dr. Priyanshu, for saying such a nice word. Actually,
this is the truth, sir.
Made my day.
I tell everybody that I learned the procedure of bone marrow from Dr. Manish Sharma, painless bone marrow.
So that is so kind of you, and I really appreciate you inviting me here. It was a wonderful talk given by you and a wonderful meeting on a rare topic. So we don't find plenty of discussions around HCC and colorectal carcinoma. So as ordered by you, so this is the talk which have been given to me. The bevacizumab from principle to practice will be talking about basic principles of angiogenesis and how does the tumor develop, what is the neovascularization, and what is the role of VEGF, followed by the role of bevacizumab in colorectal carcinoma. So these are basic slides. We'll be rushing through them. So these are hallmark of cancers, and we know the cells, they have sustained proliferative signaling, they evade growth, suppress the responses, activate invasion and metastasis, they induce angiogenesis, and then resisting cell death is important hallmark of cancer. And today we are focusing on the inducing angiogenesis. And as we know that there is a angiogenesis switch. Before the tumor, they develop in a bigger size, less than 2 millimeter of the tumor, they derive their blood supply from diffusion, and not much blood vessels they are needed. But as the tumor progresses, it needs multiple other growth factors and angiogenesis factors such as FGF, TGF beta, PLGF, and ECGF, which lead to the vascularization of the tumor, and then the tumor enlarges. And this is basically called as angiogenic switch. From the beginning till end, we can see that one thing is very, very common, that VEGF is expressed in each phase of the tumor, whether it is less than 2 millimeter in size or more than 2 millimeter in size, and it has started doing invasion and angiogenesis. So there is a critical role of VEGF throughout the angiogenesis, and activation, it occurs at various stages of tumor development. Angiogenesis is mediated primarily via interaction of VEGF-A with VEGFR2, and it facilitates the survival of existing endothelial cells, contribute to the vascular abnormalities. It stimulates new vessel growth. These new vessel growths leads to the increase in the size of the tumor. And bevacizumab prevents the binding of VEGF to these receptors. Bevacizumab has a longer elimination half-life of approximately 20 days. which can contribute to the continuous tumor control. How to get rid of this toolbar? I'm not able to hide it. So precise VEGF inhibition may facilitate the combinability and avoiding off-target toxicity. It contributes to the ability to combine bevacizumab with chemotherapy and avoid occurrence of off-target toxicities seen with strategies that inhibit multiple pathways. So in year 1500, it was known that there is a process of angiogenesis, but only in the later part of this century, we were able to discern how to inhibit this VEGF receptor. And bevacizumab is in 2004 demonstrated the major overall survival benefit in phase 3 metastatic CRC trial, and in 2011 bevacizumab was approved in 5 major indications in more than 10 lakh patients treated with bevacizumab. So it can be effectively combined with various chemotherapies such as Xelox, Folfox, or Folfirine MCRC, with platinum-based chemotherapy in NSCLC, paclitaxel, capecitabine in breast cancer, RCC with interferon, and GBM. It is a recombinant humanized anti-VEGF monoclonal antibody. 93% is human and 7% is murine. And it recognizes all the major form of VEGFR. And the terminal half-life is between 17 to 21 days. Mechanism of action, it leads to the regression of the existing tumor vasculature. It inhibits new vessel growth. And very importantly, it is anti-permeable. So those vasculature which survives, they become anti-permeable. Early continued effect results in the maintenance of more functional and normal vasculature, potentially improving drug delivery and inhibition of tumor growth and metastasis. So regression of tumor vasculature. This is without bevacizumab and this is with bevacizumab. You can see there is decrease in tumor vasculature. There is regression of the tumor vasculature leading to the decreased microvascular density, reduced tumor blood flow by weight and volume, and leading to the reduced tumor size. As there is the inhibition of new vessel growth, you can see on the right side of this cartoon, the tumor size shrinks. There is suppressed angiogenic activity, leading to the slowed growth of the tumor. There is inhibition of new vascularization, that is new vessel development, and this provides continuous control over tumor growth. On the right-hand side, you can see a cartoon with the bevacizumab, and on the left-hand side, without bevacizumab. There is anti-permeability effect of bevacizumab on the surviving microvasculature, leading to decreased edema. And this is also called as normalization of vasculature. You can see on the left-hand side, the tumor vasculature is leaky, while on the right-hand side with bevacizumab, there is normal vascularization of the surviving vessels. The reduction in the vessel permeability leads to the reduction in the vessel diameter, decreased vessel permeability, and decreased interstitial fluid pressure. Continued bevacizumab to prolonged angiogenesis inhibition and maintain tumor control. So as this was the initial diagram which we saw, VEGF, it is expressed continuously over the period of time, initially from the starting of the tumor when it is very small till the time there is invasion and metastasis. So it is expressed throughout the tumor progression. It facilitates angiogenesis, and even as the secondary pathways emerge, VEGF is continuously expressed. And hence, this is a genetically stable target, which we can target with the help of bevacizumab. It attains tumor control and maintains tumor control also with the continued use of bevacizumab as a maintenance, which we frequently follow in CA colon and CA ovary. So due to continuous VEGF expression and potential for vessel regrowth, pivotal clinical trials have been designed with bevacizumab continued until progression, as we saw in previous diagrams as well, or unacceptable toxicity. And it is recommended that bevacizumab be continued until progression of the underlying disease clinically. So in summary, angiogenesis is key driver of the tumor development across multiple tumor types. VEGF is early and persistent promoter of tumor angiogenesis, and bevacizumab targets VEGF precisely to inhibit angiogenesis, leading to the regression of the tumor growth, the inhibition of new blood vessels, and anti-permeability effect of the surviving vasculature. It can be easily combined with the conventional treatment, and bevacizumab first line maximizes the clinical benefit through the proven control of the tumor growth. So with this background, I will talk about few clinical trials in metastatic CRC, although the bevacizumab is indicated in multiple clinical conditions such as non-small cell lung cancer, RCC, relapsed glioblastoma, and advanced ovarian cancer. So coming on to the few initial trials in colorectal cancer, there are two important clinical trials, the phase 3 trial. So this was the time initially when it was not known whether the left-sided tumor or right-sided tumor have a more benefit with bevacizumab or EGFR inhibitors. So two randomized phase 3 clinical trials, AVF2107G, which showed improved PFS and overall survival, the bevacizumab combined with IFL regimen, that is irinotecan and 5-FU and leucovorin, and there is significantly improved PFS in the when bevacizumab was combined with FOLFOX or Xelox in the first line setting. In the second line setting, there is the trial in which the FOLFOX was combined with bevacizumab, and it showed improved PFS and overall survival. We will be seeing in the next few slides. And we will be also discussing and seeing the BEAT trial and ARIES and BRIGHT trial, which are large non-randomized routine oncology practice clinical trial. That is the trial from the clinics which we have, and these are basically observational studies. So this is the trial schema of AVF2107G, first-line bevacizumab in metastatic CRC. So these were patients who were untreated. First-line treatment was given with IFL versus placebo plus IFL versus bevacizumab plus IFL. So the patients, they were randomized in 3:1 fashion. They were treated till progressive disease, and the primary endpoint was overall survival, overall response rates, PFS, and duration of response. So clearly, we can see in this clinical trial curves separating very early in the treatment, and 1 year OS rate was 63% in placebo versus 74% in bevacizumab plus IFL arm, and the median overall survival was 15.6 months versus 20.3 months in the experimental arm. Similarly, this combination also improved progression-free survival as well, and clear difference of around 4 months of progression-free survival in the experimental arm versus placebo plus IFL, and hazard ratios were statistically significant to the tune of 0.54. Similarly, overall response rates also improved from 35% to 45% in the combination arm with bevacizumab plus IFL versus placebo. And there was no subset in which the bevacizumab treatment did not work, and the KRAS mutation, irrespective of KRAS, BRAF mutation status, or P53 mutation or overexpression status, there was clear advantage of combining bevacizumab with IFL. This was first-line treatment of bevacizumab in metastatic CRC, in which the Xelox or FOLFOX was combined with bevacizumab 3 weekly in the doses of 7.5 milligram per kg versus placebo plus bevacizumab or Xelox. These patients, they were also treated till progressive disease, and there was clear suppression of curve, although they met after some period of time, but there was clear PFS advantage of around 1.4 months in the experimental arm compared to the placebo, and the hazard ratio was statistically significant. But there was no difference in overall response rates, and there was no difference in overall survival, although numerically overall survival was better, but it was not statistically significant. But it was noted that those patients who had bevacizumab continued after progression, they had statistically significant progression-free survival advantage. And you can see here that those patients who continued bevacizumab after progression, the PFS was 10.4 months versus 7.9 months in those patients in which it was stopped. This is the real life study for BEAT study for bevacizumab. The continued PFS data was consistent from the phase 3 trial. You can see that the PFS was 10.8 months in the bevacizumab arm. This is second line bevacizumab in metastatic CRC, and the patient, they were exposed to bevacizumab in combination with FOLFOX or bevacizumab alone or FOLFOX 4 regimen. These were previously treated patients, and total of 820 patients they were there. Overall survival was better in the combination arm, 12.9 months versus 10.8 months in the FOLFOX arm, and 1 year rate was 43% versus 56% in the combination arm. Similarly, there was significant improvement in progression-free survival as well, and there was gain of 3 months in the combination arm versus chemotherapy alone arm. There was significant difference in the overall response rates also, 9% in the chemotherapy arm versus 23% in the combination arm. This was a real-life study, BRIGHT study, previously untreated, unresectable patient exposed to chemotherapy plus bevacizumab, treated till progression, and few patients they received bevacizumab after progression. 642 patients received bevacizumab after progression, 531 did not receive bevacizumab, and 253 did not receive any treatment. And you can clearly see the separation of curves here. Those patients who received bevacizumab after progression, they did significantly better, and the estimated probability of OS was significantly better in these patients as compared to those patients who did not receive bevacizumab after progression. This is the efficacy overview of bevacizumab in the initial pivotal clinical trials for metastatic CRC. Hazard ratio for overall survival in first line IFL plus bevacizumab was 0.66, was statistically significant. In the second line, similarly in the first line, hazard ratio for PFS was 0.83 in the Xelox plus bevacizumab arm or FOLFOX plus bevacizumab arm. And in the second line also, the hazard ratios for OS were statistically significant.
Sir, we would like you to conclude in a minute as it has already
this
gone.
is my second last slide, yes.
Okay,
yes.
okay.
So the median overall survival, either with the irinotecan based treatment or oxaliplatin based treatment, you can see it has crossed more than 20 months in combination with bevacizumab. So coming on to the summary, combination of the bevacizumab with standard chemotherapy significantly improves overall survival in first line and second line setting. Overall survival benefit irrespective of KRAS status. Consistent efficacy in the clinical trial and routine oncology practice, and continuation of bevacizumab until and beyond progression appears beneficial. Thank you so much for your patient listening. So I was allotted 20 minutes and I think I am on time.
Thank you, sir. Thank you for finishing in time. And sir, what is your preferred dosage and experience with bevacizumab? I mean, I know we have used it a lot in ovarian and colon. But
Dr. Priyanshu, we know now we have the segregation of left side and right side tumor, and we have enough data for left and right side. So for right side, mainly we use bevacizumab. On left hand side, as you rightly mentioned, either of EGFR inhibitors, they are there. So if we are giving 3 weekly, 7.5 milligram. If we are giving 2 weekly, it is 5 milligram.
5 mg. And sir, what about in non-affording patient left side? Are you using Bev along with chemotherapy?
Yes. So is it not that it doesn't work at all? So those patients who are not affording, we have data that right-sided tumor also, left-sided tumor also do respond to bevacizumab, although not to the extent that the EGFR inhibitors.
Yes, sir. Okay,
Sir,
so thank you, sir.
can we?
Yeah, we can move to the next session. I think so. Dr. Praveen is right now not available. So he can present at the end of the session. And so is Dr. Pankaj available? Dr. Pankaj, are you there?
Sir, he just left. मैं एक बार connect करके बता. Yeah, he joined, sir. He joined, sir.
So I'll share the slides from my side.
Sure,
Yeah, sir.
sure,
Good
sir.
evening, sir.
Yeah, good evening. Yeah.
So Dr. Pankaj is again one of my gurus, and he is a consultant, senior consultant, medical oncology at RGCI Delhi. And sir will be presenting a few updates in DI oncology from this year itself. Over to you, sir.
Just a minute. Yeah, good evening, everyone, and thank you, Priyanshu, for that kind words. So it will be a CCU independent conference highlights of the ESCO GI Cancer Symposium. So we'll be discussing basically about the Himalaya trial, which was durvalumab plus tremelimab as first-line treatment in patients with advanced SCC. So this was the schema. It was the first was the combination of tremelimab and durvalumab, that is STRIDE, then durvalumab alone, then sorafenib alone, and then tremelimab and durvalumab in another combination, that is 75 mg per week, 4 doses, as compared to 300 mg for 1 dose in the STRIDE study. And similarly, the durvalumab was also used in a different manner. So Himalaya OS for STRIDE, when it was compared, the combination was compared with sorafenib, it showed a median OS of 16.4 months compared to 13.8 months in the sorafenib arm. Hazard ratio was 0.78, and p-value appears to be quite significant, 0.0035. And while single agent, when durvalumab was compared with sorafenib, it again showed an improvement in OS, but the hazard ratio was a bit less, 0.86, and improved from 13.8 months to 16.6 months. So if we see the subset analysis, in most of these, it was favoring basically the STRIDE arm, whether it was age, sex, or etiology, whether viral etiology. So all of them actually supported the STRIDE combination. So PFS, if you see, compare STRIDE versus sorafenib, time PFS was 85.2 months. In STRIDE, durvalumab it was 88.7 months, and sorafenib it was 84.1 months. And median PFS was 3.78, 3.65, and 4.0 n. And the hazard ratio was 0.90, 1.02. So they were not very different if you talk about the PFS. Tumor response in the STRIDE, the overall response rate was 20%. In durvalumab, it was 17%. Sorafenib, it was quite less, just 5%. And we have to see that in the STRIDE, 3.1% patient even had a CR. Median duration of response was highest with STRIDE, 22.34 months. Durvalumab, it was 16.82 months. And sorafenib, 18.43 months. Safety and tolerability, any adverse event, they were more or less same. If you see STRIDE 97.4, durvalumab 88.9, and sorafenib 95.5. But grade 3-4 events were highest in STRIDE and sorafenib, but durvalumab, they were lesser. It was 50% in the STRIDE and sorafenib. Durvalumab, it was 37 months. And hemorrhages because of these side effects were seen in STRIDE in 2%. So investigation's conclusion was that Himalaya was the first large phase 3 assessing mono or combination immunotherapy through the long-term follow-up in a diverse SCC population. It was non-inferior to sorafenib with favorable safety. Combination of a single priming dose of tremelimab plus durvalumab in the STRIDE regime yielded superior efficacy and a favorable benefit risk profile compared to sorafenib. So they proposed STRIDE regime as a novel first-line standard of care systemic therapy for SCC. Then we had this another trial, pembrolizumab in previously treated SCC. So study design was the patients were adults and who had documented regulatory progression, BCLC stage C or B, Child-Pugh A, life expectancy more than 3 months. They were randomized either to pembrolizumab or placebo, and the primary endpoint was OS. So if we see the overall response rate, it was high, 13.7 months in pembro arm, while placebo it was hardly anything, 1.3. And median OS was 14.6 in pembro, placebo it was 13, and hazard ratio was 0.79. And 12 months TFS, if we compare, then it was 15.9 months in the pembrolizumab arm, while in the placebo arm, it was 1.4. Exposure to subsequent therapy. So, pembro plus best supportive care, around 50% of the patients did receive some sort of subsequent therapy. In best supportive care, it was 66.7 months. So treatment-related side effects, 66.9 in pembro, 49% in placebo. And investigation's conclusion that was that the pembrolizumab can be considered as the one of the treatment choices when the patient has been exhausted on 2 or more lines of treatment as compared to the best supportive care. With that, I'll conclude, and if there are any queries or any suggestions, we can have them.
Thank you, sir. I think so. We don't have any questions. So, any experience of Durva in HCC right till now?
No, I haven't used it.
Would you be tempted? But
Yeah,
the cost is a little higher.
Yes, there are some patients who can afford. So in those particular patients, we can offer, because many patients come up with that they want immunotherapy.
Okay. Thank you, sir. Thank you so much.
Yes, sir. I'll invite Dr. Priyanshu Chaudhary, sir, for the next talk. And this session is sponsored by DRL. So, sir, you can start.
Yeah, I think so. We are right now just about on time. So I'll be, a little bit on the supportive care. We've been discussing uncommon topics a little, HCC and CRC till now. So now for supportive care, anemia being one of the most common side effects, especially in GI cancers. So I'll be discussing the optimal use of erythropoietin stimulating agents in chemotherapy-induced anemia. So if we go back and to the physiology of erythropoiesis, we see that erythropoietin is essential for terminal maturation of erythrocytes, and erythropoietin rescues neocytes from apoptosis. Erythropoietin helps to sustain RBC proliferation and differentiation. The erythropoietin acts on the burst forming unit erythroid and the colony forming erythroid series cells, which further lead to erythroblast and then to reticulocytes and erythrocytes. So for the chemotherapy induced anemia, we have various options for treatment, and it can be the easiest and the fastest is the blood transfusion, and then the other one is the iron therapy, which can be oral or parenteral, and it is usually based on the evaluation of iron status. It can be combined with EPO stimulating agents that we'll be discussing, and third is the erythropoietin stimulating agents, which we'll be discussing today. The ESAs can be short acting or long acting. Short acting are apoietin alpha, beta, and theta, while the long acting is the dapapoietin and dapapoietin alpha. And the half-life of short acting is usually around 24 hours, while the long acting have a half-life of approximately 74 hours. The dosing frequency in the short acting is usually daily or weekly, while that of long acting is weekly or 3 weekly. Now coming to the efficacy, we have a large meta-analysis showing the efficacy of ESA versus control or with the long acting versus short acting. So these are the various trials. We see the subgroups. There was an increased hematological response and a decreased transfusion risk with the ESAs compared to control, while there was not a very significant difference between the two types of ESA, that is dapapoietin and apoietin. So any of these can be used depending upon the patient comfort, but definitely we'll see that longer acting ones are slightly better and easier to use. Then again, there was a health-related quality of life meta-analysis, which showed that treating to high target hemoglobin level, that is more than 12 gram per deciliter, is accompanied by improved health-related quality of life scores. that is the fact fatigue, and any clinical significance of the improvement is likely to be small. So the guidelines recommend, the ASMO and the ASCO guidelines recommend HB level of approximately 12 gram per deciliter without RBC transfusion, according to ESMO, and the ESCO says that it may be increased to the lowest concentration needed to avoid or reduce the need for RBC transfusion, which may vary by patient and condition. So when to administer, ESMO says ESA therapy is recommended in patients with symptomatic anemia who receive chemotherapy or combined chemoradiotherapy, and patient with an HB less than 10 gram per deciliter, as well as patient with asymptomatic anemia who receive chemotherapy and present with an HB level less than 8 gram per deciliter. And ASCO as a specific indication, that is ESA may be offered to patient with chemotherapy associated anemia whose cancer treatment is not curative in intent, that is very important, and whose hemoglobin has declined to less than 10 gram per deciliter. Now coming to the dosing and titration, for short acting, you can use Epoetin alpha 150 units per kg 3 times a week by subcutaneous injection, or 40,000 units every week by subcutaneous injection, while darbepoetin can be used at a dose of 2.25 microgram per kg every week by subcutaneous, or a flat dose of 500 microgram every 3 weeks. If there is no response, then the titration in Epoetin weekly is by from 150 to 300 units per kg 3 times per week, and from 40,000 to 60,000 units, while for darbepoetin it is weekly is from 2.25 to 4.5 microgram per kg every week if there is no response. The dose should be adjusted for each patient to maintain the lowest HB level sufficient to avoid RBC transfusion. If HB levels reaches a level needed to avoid transfusion or increases more than 1 gram per deciliter in any 2-week periods, then the dose should be reduced by 25% for Epoetin alpha or 40% for darbepoetin alpha. Then alternative regimens include darbepoetin alpha 100 microgram per microgram fixed dose every week by subcutaneous injection, or 200 microgram every 2 weekly, or 300 microgram every 3 weekly. And Epoetin 80,000 units every 2 weekly, or 120,000 units every 3 weekly can also be used. Then coming to the risk of thrombosis, and the ESAs increase the risk of thromboembolism. Meta-analysis and individual RCTs consistently report a 50% to 75% increased risk of thromboembolism and vascular arterial events among patients receiving ESA therapy. The special attention should be given to patients with multiple myeloma who are being treated with thalidomide or lenalidomide and doxorubicin or corticosteroids, since they are at a particularly increased thrombotic risk. Now, there have been concerns regarding the risk of tumor progression with the use of ESAs, and the proposed mechanism include a direct effect of exogenous EPO on tumor cells to induce signaling through a functional EPO receptor, which may contribute to tumor progression. Now, but the various guidelines as well as the studies have conflicting results regarding the overall survival. There are 4 studies which have shown a decreased OS with the use of ESAs, while 2 studies have shown no decrease in the overall survival with the use of ESAs. So in the late 2000s, the safety of ESAs was discussed when meta-analysis suggested that ESA treatment may affect mortality in cancer patients, particularly if target HB levels exceeded 12 gram per deciliter. Hence, for various meta-analysis suggested ESA did not affect tumor progression, and the recommended HB target range for ESA treatment is 10 to 12 gram per deciliter, and an HB rise of more than 2 gram per deciliter over a 4-week period should be avoided. So management of anemia and iron deficiencies in patients with cancer, the ASMO guidelines suggest that there is currently no clinical evidence, neither single studies nor meta-analysis, indicating an effect of ESA on stimulating disease progression or relapse when used within label and following recommendation for the treatment of chemotherapy-induced anemia. What are the recent evidences? And this was again a randomized double-blind placebo-controlled phase 3 non-inferiority study of the long-term safety and efficacy of darbepoetin alpha for chemotherapy-induced anemia in patient with advanced NSCLC, which was published in JTO in 2019. It included patients with stage 4 NSCLC who were expected to receive 2 or more cycles of myelosuppressive therapy with a HB of less than 11 gram per deciliter. The patient were randomized 2:1 to blinded 500 microgram darbepoetin alpha or placebo every 3 weeks. The primary endpoint was overall survival, and the secondary endpoints were PFS and incidence of transfusion or HB less than 8 from week 5 to end of the efficacy treatment period. So one of the very important aspect of this study was it included a lot of Asian population, and around 503 patients were enrolled from India. So the overall results showed that darbepoetin alpha showed non-inferiority to placebo for overall survival, and the median OS was 9.46 months in the darbepoetin alpha group and 9.26 months in the placebo group. So it is one of the few trials where you are actually proving that this therapy has an non-inferior OS to the control arm. So again, darbepoetin alpha showed non-inferiority to placebo for PFS also. The median PFS was 4.4 months in the darbepoetin alpha group and 4.27 months in the placebo group. The adverse events, the most common adverse events of interest were hypersensitivity and embolic and thrombotic events, which were 5.3% in the darbepoetin and 4.1% in the placebo group. And the most frequently reported adverse event in the embolic and thrombotic category were pulmonary embolism and DVT. So what is the Indian data we have now? Indian experience also. This is a real world study of CRESP in the management of chemotherapy-induced anemia in cancer patients. 274 patients were enrolled in this. It was a retrospective audit, and it was done to document the use of darbepoetin biosimilar, that is CRESP, in a real world clinical practice. And patients with advanced cancer receiving myelosuppressive chemotherapy and whose baseline HB was less than 11 gram per deciliter were included in this study. So all patients received potentially myelosuppressive combined chemotherapy, 2 or 3 combination protocols for 6 to 8 cycles, and 39% patient received platinum-based chemotherapy. Others received gemcitabine, pemetrexed, 5-FU, docetaxel, paclitaxel, capecitabine, and adriamycin. Darbepoetin alpha was administered in the dose of 500 micrograms subcutaneous 3 weekly, and the doses were given for a median of 4 times with a range of 1 to 8 times. So 233 patients were able to complete the intended chemotherapy, and if we see, there was a statistically significant improvement in the HB from baseline of 8.9 to 11.2 was the mean HB levels, and there were improvement in all the anemia symptoms, that is fatigue, dyspnea, weakness, headache, and myalgia at the end of chemotherapy compared to the baseline. The toxicity was again in line with the published literatures, that is the hypertension and thrombosis, which were of concerns, and the drug was discontinued due to toxicity only in 2 cases, and 8 patients needed a blood transfusion. So this is the largest data on the use of CRESP, that is darbepoetin biosimilar, in cancer patients from India. And administration of long-acting CRESP allowed seamless integration into the patient's chemotherapy schedule without increasing the need to visit healthcare professionals or hospitals. The median increase in HB levels from baseline was 2.3 gram per deciliter, indicating a very good response, and the toxicity was in line with the published literature, and there was no unexpected or new safety concerns. 8 patients required RBC transfusion, and 2 cases where CRESP needed to be discontinued due to toxicity, giving an overall failure rate of only 4.29%, which is very impressive. There was symptomatic improvement in all patients with respect to anemia-related symptoms. Thus, correct use of ESAs to treat anemia in cancer patients receiving myelosuppressive chemotherapy is appropriate, safe, and beneficial. So if we know when to use, we should also know when not to use. The recommendation against the use of ESA as by the NCCN are that patients with cancer not receiving therapy, patient receiving non-myelosuppressive therapy, and patient receiving myelosuppressive therapy, chemotherapy with a curative intent. So these are the patients where we are not to use ESAs. So there is not enough evidence to support ESA use in these patients. Therefore, ESA is not recommended at this time. Now, coming to the summary, if we see what are the various methods to treat anemia, chemotherapy-induced anemia in our clinical practice, they can be erythropoietic stimulating agents, IV iron, or RBC transfusion. So what are the benefits and risk if we start from RBC transfusion? The benefit is it causes an immediate increase of HB. It has the fastest route. There is a rapid improvement in anemia-related symptoms. But the limitations are transfusion reactions, circulatory overload, transmission of any pathogen. Then you can have increased risk of infection. While the second is the IV iron, it is usually done in the correction of iron deficiency anemia only. It may increase response to erythropoietic stimulating agents too. So risk or limitation in the long-term safety is not yet established, and also it can have transfusion reaction too. So the benefit of ESAs is a reduction in the need for RBC transfusion and an improvement in anemia-related symptoms, while the risk or limitations include the increase in thrombotic events, pure red cell aplasia in rare cases, and increased mortality in patients receiving no cancer therapy or only radiotherapy. And it is effective only in 60% of the patients, and the induction of functional iron deficiency and decreasing response over the time may be one of the limitations. So thank you. That is all we have for tonight. I think so we have a question. Yes, I agree that EPOs are approved in chemotherapy induced anemia in advanced disease only. I agree with what has been typed. I think so we have Dr. Praveen is here. Sir, welcome.
So hi Priyanshu, I'm very sorry for...
No issue, sir. We have kept your talk at the end right now.
So I think I'm audible. I'll share my slides.
Sure, sir.
I think it is visible.
So we can present your slides if you want.
No, are my slides visible or not?
Yes, sir. They are visible now. Yes, they are visible.
Okay. So good evening, everyone. I'm here to present the very important topic of colorectal cancer. So there are a lot of biomarker-driven treatments which are available recently, and we are using these treatment in few of our patients who are eligible for these therapies. So we will discuss all of these therapies one by one. So these are the factors which influences treatment choices in metastatic CRCs. So there are some patient-related factors which suggest us. So what should be the intensity of treatment we should use regarding performance status, comorbidities, age of the patient, the prior adjuvant treatment which patient received, and what was the response to that treatment. So there are some tumor characteristics or tumor related factors also, like if the patient is having a tumor burden which is quite high, so we are more keen in using triplet based treatment rather than doublet treatment. So if the patient is potential, so intensify to much regarding the recent retrospectives of tumor location, whether it is right sided or left sided, so that influences our choice of biologic therapy. So apart from that, there are molecular characteristics. Most of these colorectal cancers, so they have aberrations in either RAS, RAS could be KRAS, NRAS, HRAS, then BRAF, then mismatch repair genes, then HER2 amplification or overexpression. So we will be talking in detail about all these things in subsequent slides. So then regarding the patient preference also, so it is very important. So there are patients who says that I'm not willing for hair loss, I'm not willing for a lot of treatment related toxicity. So where you have to go ahead and stick to the doublet based treatment, and that to oxaliplatin. So then regarding the toxicity profile, so these are all the factors which we always consider while selecting the treatment for metastatic CRC. So these are the standard of care biomarker testing in colorectal cancer. So we can see over here the genomic landscape of colorectal cancer, and there are a lot of newer aberrations which are found in the NGS testing, because a lot of our patients, they are going ahead with the broad gene-based panels or also comprehensive genomic profiling, and we are able to identify a lot of these aberrations. But conventionally, we used to focus towards the RAS, BRAF, and now we are doing an extended panel where we are also considering the MSI testing, MMR testing, any of these two. Then apart from that, HER2, NTRK, and there are more like PIK3CA. So we are doing all these testing just to select our therapy and for the prognostication of the patient. So this is the paper which was the recommendation of the ESMO, which says, so this is a paper of 2020, and they recommend that most of the hotspot mutations, so they are found in the KRAS, NRAS, BRAF, and considering that MSI status is determined by IHC or PCR, so I think most of the patients should proceed for these hotspot testing rather than doing a broad gene-based panel. But nowadays, so we have a lot of targeted therapies. So I think it is prudent to discuss with patient regarding the broad gene-based assays, that we have targeted therapies available for them, and then we can proceed for them. So apart from those patients where tissue is an issue, so liquid biopsy also has come to rescue us. So there is ctDNA for comprehensive genomic profiling, which is ready for the clinic, but still optimizing. So when we should use it and how we should use it. So usually we go ahead with ctDNA based testing at the time of diagnosis of metastatic disease, or we can also go ahead with it during the treatment of metastatic disease at the time of progression, or sometimes, so there are experimental experiments going on regarding the early progression, detection of early progression with the ctDNA assessments. So these are the general treatment algorithm for metastatic CRCs. So usually the conventionally the first line treatment, now it is on the basis of the location of the tumor. So if it is a right-sided tumor, so we go ahead with the first line chemotherapy doublet or triplet along with the bevacizumab based treatment. If it is a left-sided tumor, so then we have to see whether it is a KRAS, NRAS, HRAS wild type or mutated, and we also include BRAF in this, and we can also include HER2 in this. So it is seen those patients who are all of these wild type, so they better response with EGFR based treatment. So left side, if it is wild type tumor, so then we go ahead with the EGFR based treatment, and if it is a mutant, then we go ahead with the chemotherapy plus bevacizumab. So particularly for some other subsets like BRAF or RAS or BRAF V600E mutation, so these are the subsets where in first line we do not change our therapy, but in subsequent line the specific targeted therapy comes into the picture. So, but in terms of MSI-H or deficient MMR, so pembrolizumab is approved as a first line agent. We will be talking about the trial in the subsequent slides. And regarding the HER2 and NTRK fusion, again, we are continuing with the conventional treatment in subsequent lines. So we can add on the targeted therapy against NTRK or HER2. So in the second line, if it is a BRAF, except the V600E mutation, so then we particularly go ahead with the treatment as the conventional treatment. If we have used the oxaliplatin based regime, we will go ahead with the irinotecan, and if irinotecan we have used in the first line, we can go ahead with the oxaliplatin. So in RAS mutation, except G12C, so the treatment remains same. But if it is a G12C, then we can use sotorasib addition to the chemotherapy agent or in these particular patients. So BRAF V600E mutation on the basis of BCON trial. So we can add encorafenib, which is a BRAF inhibitor, along with the EGFR inhibitor, and we can get a better outcome. So regarding the MSI-H or deficient MMR, if we have not used the immunotherapy or immune checkpoint inhibitor in the first line, we can add immune checkpoint inhibitor in the subsequent lines. And regarding the HER2, so there are a lot of trials, so we will be discussing about these. So coming to the RAS and BRAF mutation, so this is the most commonly found mutated oncogene in the in whole of the body. So if we see 90% of pancreatic cancer, 45% of colon cancer, and 35% of lung cancer, so they are KRAS mutant. And these KRAS and NRAS mutation, these the patient with CRs where these KRAS and NRAS mutation is present, these patients should not be treated with EGFR directed therapy. And if we see particularly BRAF mutation in CRC, so BRAF mutation occur most frequently in the V600E, and it is almost found in 10 to 15% of patients with CRC, and they are mutually exclusive with the RAS mutation. So this is the BCON CRC trial. It was a 3-arm trial in patients with BRAF V600E mutated metastatic CRCs after the failure on 1 to 2 previous line of treatment. And it was a 3-arm trial where one arm was the standard of care, which is chemotherapy with cetuximab. The second arm was encorafenib, which is a BRAF inhibitor along with cetuximab. And the third arm was the triplet therapy where binimetinib, which is a MEK inhibitor, was also included to the experimental arm. So the primary endpoint of this trial was overall survival and overall response rate for triplet versus control. And the second endpoint were the OS and overall response rate for the doublet versus control, and the PFS and the safety. So we can see here that the left side graph is for the triplet versus control, and the right side graph is the doublet versus control. We can see over here that the median OS with the triplet or with the doublet, so it was 9.3 months, which was much improved as compared to the control arm, which was 5.9 months. If we see the overall response rate with the triplet regime, so the overall response rate was best, which was 27%. Then the doublet regime, it was 20%, and the control arm, which was the chemotherapy plus cetuximab, was very feeble 2% of overall response rate with this. So what we can make out from here is that CRC, it is always better to include BRAF inhibitor in the regime. We can see the similar kind of graph in the PFS also. So there was a improvement in terms of PFS also in favor of MEK inhibitor plus BRAF inhibitor, and in the doublet with the BRAF inhibitor. So we can see over here with a hazard ratio of 0.42 in the triplet and hazard ratio of 0.44 in the doublet regime. So on the basis of this, so both of these regimes, so they have better outcome. And if we see the adverse profile, so we can see over here that the doublet regime, so however it does have the triplet regime doesn't much advantage over the doublet regime. However, there was no one-to-one comparison which was performed with the triplet and doublet. So it is a comparison which is an indirect comparison, and we can see over here so that the tolerability of doublet regime was way better than triplet regime, and the efficacy of doublet regime was almost equivalent to triplet regime. So on the basis of this, so the doublet regime, that is the encorafenib plus cetuximab, it has become the standard of care the subsequent line, the BRAF mutant metastatic CRC. So coming to HER2 amplification, we can see over here, these are the studies which shows that HER2 amplification is found in the cancer in 2 to 3% of the patient. And we can see over here that this was the ACLAS trial, so which was a trial which had seen the efficacy of trastuzumab for previously treated metastatic CRC. And we could see over here that the overall response rate with the trastuzumab plus lapatinib was 30%, which was very good. And with this, the era of HER2 directed therapy in CRC started. Then my pathway tried to look at the trastuzumab plus pertuzumab in the similar subgroup of patient, and again they saw a overall response rate of 30.9% in the KRAS wild type. So it was a basket trial, and it had included all sort of cancers which were non-breast, non-GI cancer, non-gastric cancers, and in this 84 patients they were having metastatic CRCs, and the overall response rate was 30.9%. So the Mountaineer trial, so it was on the basis of, it was with the tucatinib plus trastuzumab in HER2 amplified metastatic CRC. Again, you can see here a tremendous overall response rate of 55%, so which was seen with this particular thing. So coming to trastuzumab deruxtecan, so which is a HER2 targeted antibody drug conjugate. And this was the trial of trastuzumab deruxtecan, so which was CRC01, and it was in the pre-treated patient where the patient has already received more than equal to 2 previous regimes, and they had and there were 3 cohorts in this trial. So the cohort A was the HER2 positive patients, cohort B was the IHC 2 plus FISH negative, and the cohort C was HER2 IHC 1 plus. And they had selected the dose of TDXD of 6.4 milligram per kg body weight, which is slightly different from the breast dose, which is 5.4 milligram per kg body weight. And what they could see was that the overall response rate in HER2 positive patients means the HER2 2 plus FISH positive or HER2 3 plus. So it was close to 45.3%. But if we see in IHC 2 plus FISH negative or IHC 1 plus, so the response rates were not very great. So if we can see the progression-free survival and overall survival, so IHC 1 plus or 2 plus FISH negative, so they had almost merging Kaplan-Meier curves, and the HER2 new 3 plus or IHC 2 plus FISH positive, so they were having a better progression-free survival and overall survival as compared to the HER2 low or HER2 ultra low subset. So if we see the treatment profile of trastuzumab deruxtecan, it was almost matching with the Destiny breast trials, and there was 8% chances, 9.3% chances of ILD with this drug. And out of these patients, 3 fatal cases which were judged to be drug related, so they were identified. So it is prudent, it is very important to
Sir, sorry to interrupt, but just 2 minutes left, sir.
Yeah, 2 minutes. Okay. So these are the ongoing biomarker-based trials. One is the encorafenib plus cetuximab plus minus chemotherapy in B600E mutant CRC, then adapsib in G12C mutated metastatic CRCs, and there are a lot of trials which are going on with the trastuzumab deruxtecan also. So coming to the final part of my presentation, that is the immune checkpoint inhibitor in MSIH. So the Keynote 177, it is a phase 3 trial where they had selected the treatment naive MSIH or deficient MMR positive patients, and pembrolizumab was tried against the investigator choice of chemotherapy. And what they had seen was that the curves, they separated at around 6 months, and median PFS was 16.5 months in the pembrolizumab arm. And we can see over here that the curve plateaued at 40% PFS rate. And now these patients, they are having a long-term progression-free survival. And if we see the subset analysis, most of the subgroups, they were having benefit in favor of pembrolizumab. And if we see the overall response rate, again, it was better in pembrolizumab versus chemotherapy. And this is the duration of response, which is a telltale sign that this drug is working for a very long time in MSIH patients. And if we see the overall safety, so it was better than the chemotherapy arm in favor of pembrolizumab. So 1 second, please. Sorry. So to conclude, pembrolizumab produced significantly and clinically meaningful improvement in outcomes versus standard of care treatment. It was associated with favorable safety profile, and it was a positive study on the basis of PFS outcome, and OS outcome is still immature. And the final thought is that personalization and individualization, metastatic CR leads to improved outcome. The biomarker analysis in all patients with metastatic CRC is extremely relevant and requires quality assurance. And these are the relevant markers which we have already discussed. So one is the MMR testing, then the RAS testing, BRAF testing, HER2, and NTRK fusion. And we do other mutation testing all depending on the clinical scenario. With this, I would like to end the talk. Thank you.
Thank you, sir, for wonderful talk on uncommon things which we deal. Probably we never think of testing for a lot of HER2 probably in colon, and with upcoming, I think so, therapies like deruxtecan, these things would definitely change. So thank you again, sir, and I think so we can conclude now. Surbhi or Ekta, if there are any final comments.
Yes, sir. So thank you so much, sir, for joining everyone. And thank you for the wonderful academic feast. Thanks a lot to my colleagues, Surbhi and Utkarsh, who has done excellent work from the beginning of the meeting till the execution. Thank you all. Good night, everyone. Thank you, sir.
Thank you. Thank you.
Priyanshu.
And good night.
Thank you, ma'am. Good night.